Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 24. We're going to talk about the Rickettsiae diseases and also Coxiella, some of the other zoonotic diseases. We'll talk about Rocky Mountain spotted fever, and then we'll talk about the presentation, diagnosis, and treatment. Welcome back to Falcon Physician Review's online review for the USMLE Step 1. This is Microbiology Module 24, and we're going to talk about rickettsial disease. Rickettsiae are small, obligate intracellular parasites. They're gram-negative coccobacilli, they're stained with Giemsa, and they depend on our host ATP, much like chlamydia. This is a table of the clinically relevant Rickettsiae species. This will be something you'll want to memorize, okay? The differences between each Rickettsia species is the organism name, the vector it uses, and the reservoir, okay? From the name of the disease, you can have a pretty good idea of what's going on. Clinically important ones that you frequently are tested on in Step 1 include Rocky Mountain spotted fever, which is the Rickettsiae organism, given to us by ticks that they get from wild rodents. Other things are less common, but they're important to know because you'll frequently see them on tests. Pathogenesis for Ricketsiae includes infection of endothelial cells by the parasite-induced phagocytosis. Then the bacteria replicate inside our cells. They destroy the endothelial cells. Then they leak blood into tissue spaces, and then there's organ and tissue damage as they move to different sites. Rickettsiae is a causative agent for Rocky Mountain spotted fever. We get Rocky Mountain spotted fever when we're bitten by the dog tick, or Dermacentor. 2 to 12 days after the tick bite, we get the abrupt onset of fever, chills, headache, myalgia, and a characteristic rash. The rash is the key to the diagnosis. It's maculopapular, it's petechial, and it's hemorrhagic. It begins on your hands and feet and spreads to the trunk. So it starts on the outside and moves to the inside. If you have that with a history of a tick bite, you should think Rocky Mountain spotted fever and Rickettsiae. The problem with Rocky Mountain spotted fever is that it creates a widespread vasculitis. So you can get symptoms in any body system. Gastrointestinal systems of nausea, vomiting, diarrhea, crampy abdominal pain. You can get respiratory failure, neurologic symptoms such as seizure and coma, and you can attack your kidneys with acute renal failure. The diagnosis of Rocky Mountain spotted fever is made clinically. You talk about the history with exposure to ticks, you've got a rash, you've got multi-system involvement, you're in trouble. Clinically, you can, in addition to your clinical findings, you have serology like the indirect fluorescent antibody tests and the Wheel-Felix test, which is positive in some people with Rocky Mountain spotted fever. You can also get false positives with Proteus infections and also with typhus, but not with Q fever. Treatment of Rocky Mountain spotted fever is tetracyclines. You can also use chloramphenicol if you need to, one of the rare uses that chloramphenicol is indicated for. We unfortunately do not have any vaccine for Rocky Mountain spotted fever. Coxiella burnetii is the causative agent of Q fever. Just like the Rickettsiae, it's an intracellular bacterium, and it has 2 antigenic phases. Q fever is transmitted to us from cattle, sheep, and goats. These animals spread the bacteria in their urine and feces, and in their amniotic fluid and placental tissue. We sometimes also can drink tainted milk and get it. Pathogenesis is that Coxiella infects macrophages. It multiplies within the phagolysosome. The macrophage lyses and releases more of the bacteria, which go to the lungs where they multiply and then disseminate into other organs and form an immune complex disease. Clinical findings of Q fever include a headache, fever, chills, and myalgia. You can have mild respiratory symptoms, hepatomegaly, and splenomegaly. Diagnosis of Q fever is through serology. Its Wheel-Felix test is negative. There's no rash and there's no vector, which is how Coxiella is different. The treatment for this disease, however, is the same. You'll want to use doxycycline. Let's do a question. In addition to the Rickettsiae species, which of the following pathogens is also transmitted by an arthropod vector? This question relies on our knowledge of the zoonoses, and we have to remember which ones are used in arthropod vector. Treponema pallidum is the causative agent for syphilis, and that's human-to-human contact. Coxiella burnetii is the causative agent for Q fever, and we get that from contaminated food or milk. Leptospira interrogans also comes from contaminated food or milk, and brucellosis is the same. Francisella tularensis, however, is transmitted by an arthropod vector, like we talked about the causative agent for tularemia. Next question. A 31-year-old woodsman develops a fever, chills, headache, myalgias, and a petechial rash on his hands and feet. You obtain a positive wheel Felix reaction with the patient's serum. This pathogen targets which of the following cell types? Now that we have the question, we have to first identify that this is Rocky Mountain spotted fever. We've got the petechial rash that starts on the hands and feet. There's only a few rashes that affect the hands and the feet, and syphilis is one, and Rocky Mountain spotted fever is another. Now we need to remember that Rickettsiae affects a particular target cell. As we go through our answers, we'll try to remember which one it is. A. Macrophages. That's tempting because a lot of the intracellular pathogens we've talked about identify and live within the macrophages. Peripheral nerve cells, we think more of leprosy, and that's not really going to be affected here. Endothelial cells is attractive because we know that's their initial target, and we know that Rickettsiae involves those cells, so that's the other one we're going to think about. Columnar epithelial cells, not so much. It's not a skin-borne pathogen, and hepatocytes, we didn't really talk about it involving the hepatocytes directly, especially when it gets started. So between A and C, C is the one we need to remember, and that's a little bit different between Q fever and Rocky Mountain spotted fever, where the Rickettsiae attack the endothelial cells, whereas Q fever is going to multiply within the macrophages. Next question. A farmer presents to you for evaluation of recent onset fever, headache, cough, and malaise. On physical exam, you note hepatosplenomegaly, but no rash. The wheel Felix reaction is negative, but the serology for the causative agent of Q fever is positive. This pathogen is transmitted by... So we know we have Q fever. They give it to us. They could just say, how is Q fever transmitted? And so we would know, we would look through, and we would remember Q fever does not have an arthropod vector. It's not through sexual contact. We don't get it through transmission or ingestion of contaminated meat, or through fecal-oral transmission, but we do get it through inhalation of the endospore form. Wrapping up Module 24, we talked about Rickettsiae, and we talked about Coxiella, the causative agent of Q fever. Both of these organisms require other animals and ticks or other vectors to give us the disease. They have characteristic presentations, characteristic features such as the centripetal rash with Rocky Mountain spotted fever, and they can be life-threatening. You should be familiar with how we diagnose these based mostly on their clinical presentation. The wheel Felix test is important to know about, and the treatment of these agents is important. Next up, we're going to go to the virology section, Module 25.